Okay, hi everyone. We're going to get started. Welcome to our Reconnect and Refresh session. So my name is Rachel Davidson and I'm the Regional Coordinator of Living Healthy Champlain. Hopefully, or more than likely I should say, if you're joining us today, you've attended one of our Living a Healthy Life with Chronic Conditions or Living a Healthy Life with Chronic Pain workshop and or the online Better Choices, Better Health workshop. So thank you for joining us today. And if you didn't attend either one of those sessions, you're definitely welcome today. And we hope you'll benefit from today's session as well. It's certainly not only for those attendees. So thank you for joining us. Hopefully you can just click computer audio if you're having any trouble hearing us, so just make sure that that is clicked there. We don't have a telephone line hooked up for this, so you can just hear us through your computer. You can send me your questions throughout the session, so we do welcome questions. Feel free to type one in anytime using the question box that you'll find on the right side of your screen, more than likely. So there's a little pane that you can click, and then you can type any questions that you may have. And we'll be happy to answer that. If I don't get to it right away, I will loop back and answer them at the end of the session as well when Dr. Finestone comes on. So he's going to come on at the second half of the presentation. We will we'll do it in the same format and we'll likely answer your questions at the end of his talk. I'd just like to do a quick poll. So if you can just let us know where you're joining us from today, you should see that again in that same pane where the questions are. So if you can just take a second and answer that poll, that would be really appreciated. Thank you for doing that. So we're going to go ahead and move into our session now. So we're just going to, throughout our session here, it'll be an hour in length, we're going to review some of the things that we touched on in the workshop, in the 6-week workshop, as well as introduce you to some new tools as well, and things that you can continue to use in your daily lives to hopefully help you manage your chronic conditions and your chronic pain. Okay. So just as a recap, we know, and one of the big bases for the workshops is the symptom cycle. When we're living with a long-term health condition, such as chronic pain, we may have many symptoms and problems. You can see some of these symptoms on this cycle. All the things on this cycle can contribute to or cause health problems, worries, and really challenge our ability to enjoy life. If they occur, they can feed on each other. If we let them, these challenges prevent us from thriving. Depression can cause fatigue, fatigue can cause stress, stress can cause sleep problems, and so on. This becomes a vicious cycle that gets worse and worse unless we find a way to break it. No matter where we break the cycle, we can stop things from getting worse and improve our lives. If we understand how these things on the cycle can contribute to increased symptoms and problems, we can learn different techniques that help break the cycle at these various points and overcome our challenges. Almost all of us have long-term health condition-related problems. These can range from pain, not being able to communicate with family and friends about our long-term health condition, to being embarrassed because we have to take medication in public. We may think these are unsolvable, but problem solving is one of the things that we can do as an active self-manager. And in fact, we're going to have a look and just review problem solving again a little bit later in the session. One thing you talked about during your, if you did attend the chronic pain workshop, would have been pacing. Now this is a little bit different than what you would have seen in the workshop, but the premise is still the same. So I just wanted to go over and just remind you in case maybe perhaps you haven't been able to continue to use pacing, or you did try it and got stuck, or you haven't yet been able to try it. This is just a friendly reminder of what it's about and how you might be able to give that a try again in your life. So pacing is all about balancing activity and rest to bring about improvements in the way you feel. It also offers someone living with chronic pain an opportunity to control the effects of their illness. And while pacing does take a lot of self-control and patience, in time you should be able to do more than you would otherwise. The word activity is used in a broad sense, so that can include mental and emotional activity, as well as a more obvious physical sort. Pacing gives you awareness of your own limitations, which enables you to positively plan the way you use your energy, maximizing what you can do with it. Over time, when your condition stabilizes, you can very gradually increase your activities to work towards recovery. So how do you design your own personal pacing schedule? So you can select any activity that you want to pace. You would need to first estimate how long you can do that task safely. So if you do have an idea, you want to look back and think of when you may have experienced a flare-up in your symptoms. So for instance, if you're gardening and you did 30 minutes and you noticed that you had a really tough time after that, maybe start with half that time and try that as your starting point. For most tasks, you'll be able to work safely for a short period of time before your symptoms become noticeable. So you want to determine the amount of time you can be active before you start to feel worse. The safe zone then would be that time period, that short period before symptoms worsen, and will be the activity time period. So you want to base your future pacing of this activity on this time period, not when you're ready to collapse or when the task is done. So you need to estimate a rest time period, enough time to recover from that short period of activity. We want to always alternate our activities with rest time. And you really want to track your progress, so that's very important so that you can look back. So you can say, okay, when I gardened for 10 minutes, I felt really good after. I only needed a 20-minute break before I could do more. Or on the opposite end of the spectrum, I did 30 minutes and I was unable to do any more activity that day because of a really bad flare-up. So by writing that down, you won't have to rely on your memory to determine what that safe zone was and what the best time frame for the activity was for you. By stopping before the pain and the fatigue set in, your body will hopefully only need to recover for that shorter period of time. So with pacing, you hopefully won't need to recover all day or all afternoon, and you will avoid those flare-ups. By avoiding those flare-ups, you actually get more done by the day's end and don't have to deal with increasing pain or fatigue if we can plan to do the activity with the alternating rest time. Are there any questions on the pacing before we move on? So I want to look at a new tool with you. And this is something, so if you have some activities maybe that you're looking to implement into your routine or something new to try that you're really on the fence about, so you may have several barriers that are standing in your way. You're unsure perhaps if you really want to take this activity on. This tool is really, really good. So when you're ambivalent or you're on the fence, you're really unsure, this is a great tool to help you work through some of those barriers. Why do I want to do this? What are some of the reasons I haven't yet to make this change? So this tool is really helpful. I'm going to show you what this looks like, and we'll walk through it step by step. One thing I forgot to mention just in the beginning of the webinar is you do have handouts as well. So you can see those in your pain, where the question pain is located as well. So you have an action plan form, the pain explanation diagrams as well that Dr. Feinstein will talk about, as well as the decisional balance, so the reason for staying the same. So you can print those off and keep them and use them again, save them to your computer. If you do want a reusable copy, we do have those, so you can certainly email me and we can send you one of those as well. If you have any trouble downloading it, we can send you an e-copy as well. So this is what our tool looks like. So it's essentially a fancy pros-con list. And at the top here, we have my changes. So you can write down whatever it is you're thinking about doing. And then it's broken up into our 4 quadrants. So our first one here is staying the same. So they are numbered. So that's the order that you want to go through them in. And so our first box here says good things about staying the same, not so good things about staying the same. And then we start to think about making that change, not so good things about changing, and the good things about changing. And then finally at the bottom here we have what is our confidence level. So we're going to go through this step by step. So my change that I've been thinking about making is starting a walking program. So I'm going to start up here with number 1. Some of the good things about staying the same is that there's no change to my current routine. And I won't have to go outside on the colder days we're still having. So we're not quite into that full summer weather. We still have some of those chilly days, and I'm not really so inclined to go outside when it's raining and it's a bit cold outside. So that's some of the good things about staying the same. Some not so good things about staying the same is that my dogs are missing out on exercise that they need. I'm not really getting any fresh air during the day, and I find that challenging. Being in an office, it's hard to be inside all day. And I do sit most of the day for work. And then when I get home, I'm often taking a nap rather than going out and getting some exercise or getting some fresh air. Some good things about making the change, or sorry, not so good things about making this change, are that I may experience some soreness when I start my program. So I'm a bit concerned about that. And I may have to purchase some new shoes. My running shoes are quite old. And given that I'm having some pain, I want to make sure that I have the proper footwear. Finally, some good things about making this change are that my dogs will get some much needed exercise. Another good thing is that, especially after the winter, we can be kind of isolated, and one of my friends also wants to start walking. So this is a chance to get out and be social as well. And finally, I'll increase my activity throughout the day, get outside, and reduce my sitting time, all which I know are very important. We hear so much now about how bad sitting is for our health, so that's concerning for me that I do sit all day. So you can see my confidence level is currently a 6. So if you did take the workshop and you remember, we want to aim to try and be around a 7 or higher. That's not to say if it's not a 7 there's anything wrong. That just means that we probably have a few barriers or concerns that we'll need to look at. So as I mentioned in the beginning of the webinar, one of those tools that we learned in the workshop was that problem solving can help us when we are experiencing some barriers, to starting a new activity or making a change. So that's what I'd like to do with you now, is just look at how I might problem solve. So looking at my 4 quadrants here, some of my barriers are that I'm a bit concerned about soreness. I may have to purchase some new shoes. And I also need to connect with my friend because I'm not sure when she wanted to start the program as well. So this is obviously very quick, but in real time, problem solving might take a little bit longer, and that's always a good opportunity to sit down with a friend or one of your children or your spouse or your partner, and they're a great source to help you problem solve as well if you're having trouble doing it on your own. So if I took stepped away and thought through this, probably what I need to do to overcome some of these barriers to starting my program is talk to my friend first of all to see when she wants to start the walking program. And then also make a plan to go to the sports store near my house and get some footwear and just get their help with picking that out to make sure I get the best footwear for me. So what we can do now that we've worked through using our decisional balance tool I've made the decision that I do want to go forward with starting a walking program. You may decide after using that tool that you, in fact, don't want to make that change, which is perfectly fine as well. So, I mean, it's better to use that tool, take that, 5-10 minutes, work through those barriers, work through why you want to do this in the first place. And if at the end of using that tool, it's really not that important to you, at least you know that now, and you can perhaps work on doing something that is more important to you rather than, taking a lot of steps and finding out that, what you're thinking about doing really isn't that important to you or practical or whatever the situation is. So it can help you work through some of those challenges. So in this case, I'm ready to start my walking program. I'm ready to make a plan around how I'm going to start that. So action planning was really a major part of the Living a Healthy Life workshops. And so I just want to review that with you. Again, this handout is also available in your little dialog box there on your screen. If for some reason you can't download that or save it, please feel free to contact us and we're happy to send that along to you. So I'm just going to review the action plan with you. So this is something that you want to do. So we can't emphasize that enough. It's not something necessarily that your doctor has told you that's really important, or your spouse, or your daughter, or your friends. It's something that's really important to you, and something high on your priority list. Change is really hard to implement, and so if it's not really high on that priority list, it's going to be hard to do. And so it's really, really important. That's why it's the first thing we mentioned, something that you want to do. It needs to be achievable, so we don't want to set ourselves up for to fail. Not to say that it can't challenge us a little bit, but it needs to be something that we can actually do, something that's within our means and resources. So we also want it to be very action specific. For example, losing weight is not an action or behavior, but avoiding snacks between meals is. So losing weight is the result of the action. We wanted to be able to answer the following questions. So what? So it could be, for example, walking or avoiding snacks. How much? For example, walking 4 blocks. When? For example, after dinner on Monday, Wednesday, or Friday. And how often? So, for example, 4 times a week. And then again, as I just mentioned, we want that confidence level of 7 or more. So you can ask yourself on a scale of 0 being no confidence to 10 equal total confidence, how confident am I that I'll be able to complete the entire action plan? So if you do rate your confidence below a 7, you might want to look at the barriers and consider reworking your action plan so it's something you're confident that you can achieve. You can also go back and use that tool if you haven't already that we just looked at and see really what those barriers are and how you might work to address them. So just an example of an action plan would be that I want to start a walking program, so very specific. And my first plan is going to be to speak to my friend by Monday about when we would like to start walking. And my confidence level is an 8 that I would do that. So as you can see, that's a very, it might seem like a very insignificant step or a very small step, but when we can break our plans down into smaller achievable steps, we're more likely to follow through with those. So that's really the first thing that I need to do to start this plan. So are there any questions on any of those tools, the action plan or the decisional balance? So someone's just asked me to show the pacing picture again. So I can just go back to that. There we are. So that just says to measure your activity, set your limit, stick to your limit, and then increase your limit very gradually. So is that okay, or are there any additional questions on that before we move on? We're done a bit early. Dr. Feinstone is here, conveniently. So what I'm going to do is I'll just hand it over to Dr. Feinstone in a moment. So just to give you a bit of background, Dr. Feinstone is a specialist in physical medicine and rehabilitation. He graduated from McGill Medical School and received physical medicine and rehabilitation specialty training at the Universities of Ottawa and Michigan. He is a full professor in the Division of Physical Medicine and Rehabilitation, Department of Medicine at the University of Ottawa, Director of Stroke Rehabilitation, Research at the Elizabeth Briere Hospital, Briere Continuing Care, and electromyographer at the Ottawa Hospital Rehabilitation Center. Very busy man. So we're very honored and grateful that he can join us today and dedicate this time to speaking to you. So he's going to go through two diagrams with you. Again, these are available in our handouts, so you can save those or print those off as well. And just to mention, just at the end of the webinar, you will receive a follow-up email, and that just has a brief survey that will be attached to it. It's only about 5 questions. So if you could kindly take the time to answer those, we do really appreciate that feedback. It helps to shape future sessions and just to let us know what you found helpful, any areas of improvement, and then we can make those changes going forward. So with that, I will hand it over.
Thank you. So we're not on visual here, we're just
no, yeah, just your voice.
Just voice. So, and where are people now listening?
They can be all across Ontario.
All right. So, and we said about 30 minutes or 20 minutes.
Yep. We have a few extra minutes.
All right. So we have been looking at this topic, or I've been asked a couple of times, and we've tried different things. We've tried different slides, and we sort of thought sometimes it's too many slides. And so for this time, we said, why don't we try to be a little bit open with our audience and try to really go a little deeper than we've gone in the past. And I guess I sort of thought when I was walking down the hall, how would I preface? I'd say anyone, and I give this in the slide sometimes, they say if someone says they know everything about, well, about anything, but if they know everything about pain management, or they're going to tell you everything there is to know, you just know one thing. You should just run away from that person, because no one has all the answers, and particularly even after one assessment or 2 assessments, and people look at the problem of having pain in so many different ways. And I guess that's what I'm trying to even appreciate at this stage of my career, of seeing a lot of people and seeing reactions of people to ideas that are presented by different therapists. Because like I say, sometimes it's very hard to be a patient, because you go to so many well-meaning, caring people. Like if you're a person and you go to your family doctor, and maybe you'll go to a specialist, and maybe you'll go to 3 or 4 specialists. You go to different therapists, you go to physiotherapists, you go to a chiropractor. Each one seems to give similar information. But let's face it, if we go for our backs, we're going to get some different kinds of information from a chiropractor who's going to tell you, look at your x-rays and look at this curve. And then if you go to a physiotherapist, they may say your posture is off. And then you go to the doctor, and he may say, it's nothing really much. It's not a big deal what you have. Don't worry about it. And then someone will say, well, what about my x-rays? And so we have discussed over the years the x-rays, like, people have on their x-ray reports, they may say things like, what are degenerative changes of my neck? And is that causing my pain? And then they'll go to some doctors who will say, yes, I think those degenerative changes are causing my pain. And then someone will say, well, a lot of people have X-ray changes and degenerative changes, and they don't cause pain. So that's confusing. And because the answer is both of those people could be right. It is true that sometimes when you look at an X-ray and it is really a lot of arthritis, it would make sense that if the type of symptoms the person's having, like grinding and pain and difficulty moving, that it would be as a result of the X-ray changes and some degenerative changes of the spine. But it also is equally very common that someone has a more muscle pain, good movement, and they have some degenerative changes, and we sort of say, that's not so important. So how does this relate to this sheet that's in front of us that you're going to have and that you could try later after this talk is over to fill it in yourself, either one, with the information that you already have as a patient and all the people you've seen, or two, going back to your therapist or going back to your doctor and after some thought yourself, trying to fill it in and seeing how you fit in trying to make sense of your pain and trying to make sense of the treatments that are important or relevant to your pain. So let's look at this sheet because this sort of gives an approach for you as the patient to think about what you have, and it gives an approach on to figure out what can we do. And of course, again, it matters who is doing this sheet with you and what are some of their thoughts and some of their ideas. And so we'll talk about that as we go through this. So I can ask more questions.
Yep. So the people can answer they'll type in if they have any questions.
So why doesn't, if anyone has any, before we go ahead and look at this, on the top left-hand corner, pain, explanation, and treatment diagram, is there anything anyone wants to just say before we're going to sort of go through this to see if there's any ideas we can obtain about pain management and treating pain? So we'll just...
Yeah, well, we can answer them as they pop up.
We'll answer them as they pop up. Great. Okay, so in the middle of the sheet is the diagnosis. Because really, if we don't have a knowledge of what's going on and what we think's happening, then it's pretty hard to start a treatment plan. Now, even this is problematic because you go to different doctors and different therapists and different people. They'll say what their opinion is about what you have. So, if you have fibromyalgia, so that may be, that's what you have, and someone will discuss with you that was one of the problems that you have. So that may be one of the things you may put, like say, on the number 1 on the top of the list there.
Yep.
So you may put 1 here. The doctor may say, I think you have fibromyalgia syndrome. Now, you may have just pain in your neck and in your back, and it seems to be more in the muscles, and it seems to happen, say, after a car accident, or it seems to happen after some fall, and the doctor doesn't think you have you don't have pain in every part of your body, which, like, fibromyalgia is pretty pains that are diffuse, means over a lot of parts. So they may say, oh, we have muscle ligament pain on number 2. You have pain in your muscles and ligaments, which another common word is myofascial pain. Pain in the muscles and ligaments, and maybe it would be good to sort of try to name which muscles, because there's a whole bunch of books and a whole bunch of thoughts and ideas about muscles causing specific kinds of pain, both, say, at the muscle level, say if the muscle was your neck. Sometimes there's things called referred pain, pain that is like inside of your head, pain is going down your arm, which could actually be happening because muscles and ligaments are injured from the trauma. Now, sometimes then we may put that degenerative changes of the back or leg, of the back or neck, because sometimes people have, and like I said, often do, some arthritis with the myofascial pain, with the fibromyalgia, and you try to piece that together and try to understand what's going on. It's not uncommon. You're allowed to have fibromyalgia syndrome with myofascial pain, with degenerative changes of your spine. That's okay. And then, of course, we want to know on the far right here, is there an actual bone problem? Did the person have a fall? Did they have a compression fracture? So this is the problem. There's lots of different diagnoses. Even the people in the room and in the various rooms across Ontario that are listening to here, they may have a chronic painful condition, a painful condition that's lasting, that's persisting, that still maybe you do from different things. So like if a bone's crushed and it's called a compression fracture, but it's not enough to cause damage to any of the nerves, they may have a bone. I guess we're talking sometimes in this chronic pain that we're talking mostly about muscle ligament pain and not so much a bone problem, but it still could be. Not so much a nerve problem, but sometimes people do have nerve problems. And that means tingling and numbness running down their arms from the neck, for instance, or from the back, electrical kind of pains. So that's called a radiculopathy, often if it's coming from the neck or back. And that's a different kind of pain. And your doctor or your therapist has to know about that kind of pain because it is different than the muscle ligament pain that we also see and which is very common. And then there's still some people who have arthritis, like rheumatoid arthritis, or problems in their joints, or various different kinds of joint problems. There's psoriatic arthritis. There's arthritis due to people who have bowel disease. If you have Crohn's disease, you may have a type of joint problem. So so we are, you know, that. So it's important to know those things because each one can cause chronic pain, but their treatments are a little different, and you think about them a little different. There is someone just wrote a question. Hi, Dr. Hillel. Could you speak briefly about a history of sexual physical abuse affects chronic pain? Do you realize I do as it's a huge topic, but if any info at this point would be helpful. Oh, that's a great question. And as a matter of fact, wrote a paper years ago on a history of chronic pain and sexual and physical abuse. And so when I will get to that in this talk, because it is part of the talk actually. And there's even a new article that I just recently read to the doctors in my group and about this. So we'll get to that. So most important, let's get a diagnosis. Let's not use just the word chronic pain. I guess that's the message. Because yes, there's chronic pain, but let's at least try to figure out, and I'm not saying it's your fault if you don't, if your doctor does just use the words chronic pain, that's too bad. I think you should still try to figure out which part of your body is hurting more, and try to understand. Because I mean, maybe we don't have to know exactly why fibromyalgia happens, but at least like yesterday when someone saw me and I said, what do you think fibromyalgia is? And they said, I think it's like compression of the nerves in my neck. And I said, oh no, that's not what it is. And I now, does it matter that she thought of that? I think it matters because if she's thinking that she's having crushing of her neck nerves, and when it's not really, that's not the case, maybe if you don't think that, maybe then you could go on to other types of treatments that you don't think are going to harm you, and you could also not be afraid. So that's important. But do we spend enough time doing this? I know that people out there are saying, I spent 5 minutes with my doctor, and I don't have enough time to talk about it. Okay, so then we say, okay, say it is muscle ligament pain, say it's myofascial pain, muscle ligaments are the pain-causing structures with a little bit of arthritis. Say, what do we do about that? So we say, okay, sometimes we make a joke, but it's not a joke. We say, well, let's do a muscle ligament transplant. Can't do that. But it's not a bad idea. Like if people have bad hearts or bad kidneys or bad lungs, they do get transplants, but we don't do that for muscles and ligaments. So we can't do that. So we have to say to you out there even to say, well, okay, so I can't get new exact parts at Canadian Tire. So, but is there any other things that I know of that could make those parts work better, have better healing potential? Yeah, the answer is, yeah, there are things. And are there things out there that make things better, and are there things that would make things worse? Because we want to know, we want to remove those things that could potentially be causing things to be worse. Yeah, so the answer is yeah, there's lots of things. So that's why we start this journey in of looking at what are some of those things that are making my muscle ligament pain, my chronic pain, as a result of these muscle ligament pain worse. So let's look at the far left. So we're not trying to blame things here, but we're saying, okay, do smokers have more pain? Yeah, unfortunately, absolutely they do. And that's due to, we think, a lack of circulation. The smoking has carbon monoxide, so it plugs up the oxygen, and it also narrows blood vessels. So if you're going to want to get oxygen into a tissue that's injured, if you scrunched your back and twisted it when doing some gardening, and you want to get delivery of oxygen to heal it and everything, and you can't because you're a heavy smoker, that's a problem. So we do say stopping smoking or cutting back or thinking about it at least is one part. We say alcohol, okay, if people are alcoholics, if they're really drinking a lot, we know that alcohol is a neurotoxin. It definitely affects and kills nerves. And so it's not a good idea when you're in a chronic painful situation to be affecting your nerves. Now diet, I know people get heavy sometimes as a result of being in pain. We're not saying that obesity causes pain. I don't think it does cause pain. Unfortunately, over the years that I've been giving this talk, there's a lot of studies that show that people who are obese do have more pain, more fibromyalgia. Is it that the cause? I don't want to say it is, but it's just something that we should be aware of. I know it's so hard to lose weight, and I know it's so hard to think about this, so we're not trying to blame anyone, but it's an issue, and it's something, like the clearest thing is arthritis effect on knee, is obesity's effect, for instance, on knee arthritis. There's a direct effect on how heavy you are and how much arthritis, breakdown of the cartilage, breakdown of the bone in your knee is. So then we move on to the second part. We say sleep. And it used to be there was a whole bunches of studies on sleep and how maybe sleep is the biggest problem since sliced bread and pain. And I think what we've come down to say is sleep is important, more so that sleep is needed. And if you don't sleep because of your pain, or if you don't sleep, you're going to be able to cope much less with your pain. So that's where, if we try to classify here, we ask the patient, the person view, is your sleep poor? Is it waking up not refreshing, as people with fibromyalgia often add? Is it good? It's a good sign if it's good. But if it's poor, not refreshing, so sometimes while we want to do this multidisciplinary, this holistic way of healing, caring for the injured tissues, we still want to say maybe we need a medication here, something like amitriptyline, something like some of the antidepressants, something like trazodone in that treatment section to just help you to sleep a little, so you'll be able to sleep, and maybe that will help you a little bit to then be able to go on to stopping smoking and the alcohol and doing some of the good things for yourself, because if you're tired and you're feeling crappy, it's pretty hard to want to do something good for yourself. Some of the medications for sleep, we're not saying they're pain, stopping drugs. We'll go on if there's any questions later. Exercise, yeah, the biggest problem is that people are not doing enough exercise, and they're afraid to do exercise. You're in pain, you have pain all over, go out, it hurts more. In general, of course, if you have a nerve compression and it hurts and it's shooting down your arm more, you don't have to do more. But in general, with people with neck pain and back pain, there's not a lot of place like for bed rest and for intense rest, because muscles and ligaments, we know over and over again, they heal better if there's some movement, if there's some stretching to them. So, this is like the Goldilocks, is not enough, too much, just right. We want to get a level that you're pushing your system, you're pushing that back. Maybe it's hurting a little bit when you're doing it, but at least it's not hurting tons that night or the next day. And you want to do something. So get into your community. Look at the aqua fitness programs. So we put sometimes in the #1 aqua fitness. Some people, some different community centers have chair yoga. They have exercise for painful conditions. There's a lot of stuff out there. You got to go look what's in your community. That get maybe help from your family doctor. There's lists of treatment places, or not treatment, just like exercise places that will have classes and will help you to get going with them. Yoga is fantastic. Yoga is not just stretching. Yoga has breathing, and it has stretching, and it has even some movement for strength. So that's great if you could find something in your community. So the message is usually people who are staying upright, sitting, not moving, it's never very good for the muscles. They can't get the blood flowing into them. They can't get the stretchiness that the muscles need. And muscles seem, it's fact, they did the studies, the famous studies on the rat tail. What's that? They took a rat tail and they cut it and stitched it back together again. And they showed that if you put a little weight at the end of the tail, it put a little stretch on it, a little tension, and the heel and the tail healed much better when there was a little tension, a little motion, a little movement. So that's why we recommend more exercise for back pain and neck pain and other things. Okay, and then we go to ergonomics, and that's like if you're at a certain job, if you're at your office, if you're in the kitchen, if you're in you're with friends at just watching TV, you could pay attention to your body and how it's positioned and what's it doing. We call this machine-body interface or connection. So like, sometimes at work, you may have the workstation of someone who was previously working there and it was 5'3", and you're 5'10", so maybe you need to lift the monitor, move the monitor, move it. You may need to get another chair. Some of these $900 chairs, they don't seem to be so much different than a chair that just feels right and is at the right height and has some adjustments to it. So it doesn't have to be sometimes fancy. A lot of people have been getting lately these desks that also move up and down with hydraulics. They're worth trying sometimes. And I mean, some of my patients do actually in the workplace, they're up and they're down, and that helps them because it's true that sitting does produce, for instance, higher pressures in the spine than standing. So it makes sense. Sometimes it's not necessary to do that, but sometimes you may want to look. Some of them are crazy expensive. And then one of my patients the other day told me that at IKEA they have a kind of desk that does raise and lower. That's not that expensive. So look into that and see if your employer or even at home, you may want to try that. Try it before. Try in the kitchen first and just put some work on books and stuff. So just see if it's going to be effective for you, because sometimes my patients say it's hard for them to stand, even though it's better for that. So you don't want to waste your money on something that's some tool. Okay. How are we doing for time, Rachel?
Very good.
Well, good. So we call these things, and I call them, and we're trying to get this into common language for you to understand risk factors, and specifically pain risk factors. Now, I use that term specifically because you listen to TV and you see, pay attention to your risk factors for stroke and heart attack. What are risk factors? Things like smoking, diabetes, high blood pressure, cholesterol, maybe a heart rhythm problem. These are things which are important for you, Mrs. Smith or Mr. Smith, to know about because they could cause a heart attack or stroke. Well, we all know we have an Uncle Sam, he's 92, and he smokes like a chimney, and he doesn't have a stroke. But we know that it's still worthwhile to say, get people to stop smoking, because they're definitely a risk factor. It's definitely a higher chance of having a heart attack or a stroke if you're a heavy smoker. No question about it. That's been proved. So we say, okay, are there any things that could be pain risk factors? In other words, if I got an injury, if I fell down the stairs, if I was in a car accident, that could make it a higher chance that I would go on to have chronic painful condition. So that's what these things are. These are pain risk factors. The habits, the sleep, the exercise, the ergonomics, things that could keep that pain going. So I know people hate when we talk about smoking. If you're a heavy smoker and you're saying, being discriminatory against me because I smoke, I have to, and it's, what can I say? I think we all have to understand that it is an addiction and it's not easy to smoke. I'm pretty impressed lately with some of my patients who are telling me, who understand why they're smoking. Like, I think 3 for 3 in the last 2 days that people say, well, I smoke because I'm stressed, and it's a stress reliever. And I don't think people said that as much 5 years ago. I don't know what you think, Rachel, but I thought that was kind of refreshing that at least they're saying, and people are recognizing why they're smoking. And then I'll often say, well, yeah, so that makes sense to me. So it's a legal drug that's out there. They could just buy a thing and helps me with my stress. Sounds good. The only problem is it causes severe vascular disease, poor wound healing, poor recovery from back pain, and cancer. So, and bladder cancer, and all these things. So it's so bad for you that we have to say, even though it's helping with your stress and it's relaxing you a little, and it is your buddy when you go, for a little brief time, we're still saying, wow, if you really want to be serious about treating your chronic pain, and you want to really see if you can improve upon it, which I think most people can, because you see they're laid out in front of you, they're out there, then it's worth it. But so let's go to the left, and one of our people here talked about other things. So sometimes I'll put my hand on this side and not bring this up, but basically we're saying what other things are pain risk factors. So life in general, financial problems, stress, anxiety, anger, fear, nightmares, a history of physical abuse, a history of sexual abuse, alcoholism, not necessarily in you even, but if you have an alcoholic parent, a father or mother, it seems to be a pretty tough thing. And my patients tell me, they say having an alcoholic parent is like there's no consistency. There's no ability to have this warm relationship, or sometimes it is warm, and sometimes for another day, the next day, doing the same thing, it's all of a sudden violent or not warm or inconsistent. So that's not saying everyone who has an alcoholic parent gets chronic pain. But no, it's a pain risk factor, and it's something to think about, and it's something to get some help for yourself if it is something that makes sense to you. So yes, there's lots of studies that show that physical abuse and sexual abuse are a little bit more attached or correlating to chronic pain, to fibromyalgia. So that paper I just told you about that I read and just came out, it's either 2016 or 17, was from Israel, and it was talking about chronic pain in people who have fibromyalgia and pain in arthritis. And they compared the group with rheumatoid arthritis with the group who had fibromyalgia. And they looked to see, do they have more episodes of physical abuse, sexual abuse, but also PTSD, post-traumatic stress disorder, and also neglect, emotional neglect, or a feeling of neglect. And what did they find? They found it was pretty overwhelming that there was much higher episodes of neglect in the people who had fibromyalgia syndrome, and they had more pain. Not in this study, sexual abuse and physical abuse didn't come out really. It was more the neglect and the post-traumatic stress and things like that. So does that mean that's the cause? No. Does that mean it could be a big cause? Well, if those things cause anxiety, cause your muscles to do things like contract, then we go to the paragraph on the far right on the bottom, and we say, well, what the heck? How can stress affect, worsen, aggravate, or cause pain? Well, I didn't make this up. This is the mind-body connection. This is something we all know, but we shy away from, and our doctors are not good enough at making this connection for you, and that's why with Rachel, I think one of the reasons she invited me, because we want to talk about these things. And it's a huge problem. I even read an article this morning because we're talking about, for instance, opioids. And we're just saying, don't prescribe them. And they're bad. But we're not saying, how do we look at the holistic way of treating the people who are prescribed opiates, who most of them are not bad people. Most of them are not addicts, or most of them are not just trying to get drugs to sell to someone else. Most of them are people who have chronic painful conditions. So what's the problem? Well, they're not being looked at in this way, and they're not having services available to them like physiotherapy for the exercise, and like maybe a massage therapist, and maybe if they had a chiropractor, and then certainly some of the people that can help here. Because what could these things cause? Well, we say adrenaline is squeezed into your bloodstream when you're anxious. Your heart rate increases. Your muscles tense up. You sweat more. Your pain increases, becomes more intense. I think we could all relate to that. When you're injured, any stress that you feel can make the injury and pain worse, not just in your mind. So it's not just we're all a bunch of dumb people. It's when we're stressed, when we get an injury, things don't knit together as well. They showed that in animals. They stressed the crap out of a mouse and injured him or her, and showed that the muscles and the ligaments, the tissues did not heal. They do not go back together as fast as when there was a good environment. So what's some of the other things? So that's where the idea of if we can treat or deal with some of these anxiety issues and some of these stress issues, then potentially we can actually make an impact on chronic pain, on fibromyalgia, on myofascial pain, muscles and ligaments. Maybe we can make an impact that you'll be able to then do the therapy, do the exercise that you need. Sometimes it's that you just calm down enough, because before, if you're getting therapy, it's like you're getting therapy and then you're having these panic attacks and not sleeping well. It's like throwing a grenade into your tissues every time. So you go for physiotherapy, you feel good for an hour or two, or half an hour, or a day, and all of a sudden you're all stressed. There's issues with your mom, you have problems with your husband who has some kind of physical illness or mental illness, and you're trying to cope with your child who has autism, and you're stressed, and then it just sets off physically again. So let's think of it in terms of physical, not just emotional pain. So that's how we're going to, so that's how the connection between the sexual and physical abuse, that's one thing. Like when we looked at it in our studies, there could be lots of different reasons. Like maybe when you're a little more distracted as a result of having come up abuse, maybe you actually get into more accidents. Let's face it, if you're stressed and anxious and you're driving a car and you're a little bit more or less aware of your surroundings, maybe you get in an accident. So maybe you have just regular pain after a car accident, but it happened as a result of different attention problems. And maybe then we said there's wound healing problems, and then it could be mixtures of different types of diseases that still have to be attended to. And so a combination, into multidisciplinary, looking at some medications that may help with sleep and depression, exercise, physiotherapy, chiropractic, massage therapy, some other individuals, looking at ergonomics, looking at the sleep picture, looking at different habits, and finally looking at how this all has an impact on the psychology, or the psychology having an impact on the pain. It goes both ways. That we hope, and I kind of know that it could be successful, but it's hard in society right now to get this kind of overall plan. Maybe we could talk about
that. Are there any questions at the moment? If you do think of anything after, we can try and answer that as well.
Sure.
Yeah, we did have the other diagram. Did you want to touch?
Yeah. Sure. If there's a little time, we just thought. So this one. So I'm not a pediatric doctor, but when I was asked to give this talk about chronic pain and about the children, then one of the another day, one of the psychologist in Montreal, one of the Montreal clinics, it was at the Montreal Children's Hospital, in the stomach, in the gastroenterology or abdominal pain department, said, "Oh, that's really interesting. I think let's try to develop your sheet for children." I think it's being used in a couple of places. Since again, I'm not a pediatrician, then I think there's one place in Wisconsin that said they were using it in their clinic. So it's the same idea. But if you have children that are having chronic painful conditions, and children do have chronic painful conditions, they're a little different. They have more abdominal pain than tummy pain than adults, but they do have neck pain, and they do have back pain. And I think in the past we've just kind of ignored kids. But the fact is they do, and there's lots of pediatricians out there that are specializing in chronic pain. It's kind of sad, in chronic pain in children. I'm on a net serve, and every day I see so many young people getting interventions and injections, and we really would like to avoid that and go first at the core. So so I guess if we're saying, if your child comes in with tummy pain, your grandchild, and if there's stomach pain going on, then first try to look, of course, the same thing. You want to make sure they have Crohn's disease, and they're going to look to see if you have any inflammation and some serious disease. Many, many times they're not like that. And you want to look at what are the factors that are going on in that kid's life that could be causing muscles to be tense. So that's one cause of tummy pain. That could be causing acid to be secreted, squirted out. And those are many different ways. So we looked there, we saw, yeah, diet. It doesn't seem, children sometimes smoke and sometimes they drink alcohol. So you want to make sure that they're not in that, because that could be causing some pains in the tummy. And sleep also is a factor. And exercise, often when you get tummy pain, exercise, get constipation, and so that's an issue. And we said in the bathroom, that's on the right side, constipation, diarrhea. But most people say these are things, they happen. They're not a huge part. A large part of that we just forget to ask is all those stuff that are on the bottom on the left. Again, we're not saying these are the only causes of tummy pain, but we're thinking of maybe in high school when they have a health class, we talk about sexuality, and they talk about use of condoms, and talk about menstrual periods, and talk about health. It probably should be a class or two of how feelings and emotions affect people's health. And with kids, how it affects your neck, Johnny, and your stomach, Emily, and how things like, so we put this list on. It was generated mostly by the psychologist who was working with me. There is the physical and sexual abuse there, but also the parents. If there's a lot of arguing going on, if there's a parent that's ill, if there's one of your brothers or sisters or stepbrothers or sisters are having troubles, and it kind of disrupts the family, and sometimes that could make one of the kids really nervous, and then it would cause, again, in a similar way, but each case is different. That's why you can't just paint this with a broad brush. Here will be adrenaline is going in your bloodstream, your heart rate increases, your muscles tense, and your stomach squirts out tons of acid. And the lining of your stomach may get irritated. So it's not just like you're imagining this stomach pain, it's real. And it could be due from inflammation. And ultimately, you could even have an ulcer. And your bowels spasm, and they don't work as well. And you could get constipation. Maybe you don't drink as much then, because you're worried about eating, and you have diarrhea because that's irritable bowel syndrome happens to that. And when you have stress, when you have stomach pain, any stress you feel can make it that much worse. And the bowel function, things like constipation, and either worse. So dealing with those issues, but presenting in this kind, open way, which is so necessary, not blaming the child, not blaming the adult, and not blaming the family, because that's the problem here sometimes. If you're seeing a child with bowel pain, or seeing the child with their family, people could feel guilty, but they were involved in the stress of their kid, and that could be problematic. But so you want to sort of throw the blame away and try to treat the child.
Thank you. So we just have about 2 minutes left, and we just have a question there.
Okay.
So it says, what do you think is the best way to approach one's family physician to get an overall treatment plan started?
Well, we only have 2 minutes. I should ask you, what do you think? Because it is true sometimes that my patients are telling me, they go to their doctor and they say, okay, you only have one problem, and that's all we can deal with today. And what do you do about that? So I think, one, do your homework. So one is bring the sheet in and fill it out first. Two, I'll give you another thing. If you're trying to describe your pain, write this down. To describe your pain, you could write down P, Q, R, S, T, U. And each of those letters stands for something that you could describe your pain in a way that it may make it a little easier for the doctor. The pain, what kind of pain is it? Is it sharp pain, dull pain, electrical pain, burning pain? Q, the quality. So that's the same thing. What's the quality of the pain? Is it so bad? Was it like out of 10, 10 being, you should never have a 10. It's terrible pain. The R, radiation, does it go anywhere? No, it stays in my back, Dr. Feinstein. No, it goes down my leg. P, Q, R, radiation. S, severity, how severe it is. Certain diseases have more severe than others. P, Q, R, S, T. Timing, just kind of, is it more just only at night? It only wakes me up when I sleep. P, Q, R, S, T, U. Under what circumstances? It's repetitious, but like it only hurts when I jog, it only hurts when I curl, it only hurts when I lean back in the hairdresser's special sink. There's different times when it may be more painful. So if you could sort of have that in advance and say, oh, this doctor told me I should divide up my payments, PQRSTU, PQRSTU, then that will help me. And I have the sheet on, and I really want to discuss, I would say I want to discuss a treatment plan for myself, and it doesn't have to be done all today, but because I want to help myself. And then if you want to get more information, yeah, there's books out there, there's fibromyalgia workbooks, there's mindfulness books you can look at, and there's my book called The Pain Detective, Every Ache Tells a Story, and it's called Understanding How Stress and Emotional Hurt Become Chronic Physical Pain. There's not a million copies out of there. Go to the library. So that's that, and most libraries in Ontario have it. If not, ask them. The Pain Detective, and it really talks about this sheet and my stories with my patients, and tries to be friendly to try to understand how you started and how you finished and what happened to these people. A lot of times people can relate to themselves by reading those stories in the Pain Detective. Any other questions?
Any other questions before we sign off? If there's any questions that you have that you might think of after you step away, don't hesitate to email me or call me, and if I don't have the answer, I'm happy to seek that out for you.
And Rachel can contact me. Be more than happy to give a response.
Yeah. And if you had any trouble downloading those diagrams or any of the handouts I provided, again, I'm happy to send those along to you, so don't hesitate to contact me. So thank you so much for joining us today. The session was recorded, and it will be on our YouTube channel as well, so I can send out that link to you, and then you can revisit and watch it again if you do have any questions. So thank you very much for joining us. Again, you will receive an email that just has a really, really short 5-question survey. If you can take the time to answer that, we really appreciate it. And again, it just gives us that feedback and helps to shape future sessions. So thank you, Dr. Feinstein, for joining us.
Thanks for having me. It was a real pleasure.